Hello, my name is Matthew Koff. I'm an assistant professor in anesthesiology and critical care medicine at Dartmouth-Hitchcock Medical Center. Today we're going to be talking about the esophageal Doppler monitor and its use in individualized goal-directed therapy in the operating room. So this is the esophageal Doppler, the cardio-Q, and this is the DP240 probe. I'm going to go over insertion and signal optimization for you. There's a bevel to the probe. There's some numbers on the probe, 1, 2, and 3, and they help guide the depth of insertion depending on whether you're going through the mouth, oral insertion, or through a nostril for nasal insertion. And I'll go over that in detail. You need to put some lubrication on the probe. That helps for both insertion and to make contact for a better ultrasound signal when you're trying to optimize and get the signal on the probe. For oral insertion, there's a bevel, as I mentioned. That bevel should be facing up, and as that bevel enters the mouth, it will kind of orient itself appropriately against the descending aorta that way. So you just insert through the mouth. Usually goes quite easily. If you feel any resistance, you should stop. Should just flow easily down through the esophagus and through the mouth. As I mentioned before, we have 3 numbers, 1, 2, and 3. I just place it to using the teeth as a guide or the lips as a guide. I place it between, on most people, between 1 and 2. If you have a very small person, you may be closer towards the 1 number. If you have a very large person, you may push it more towards the 2 number. But that gives you a quick rough range about where you're going to obtain your best signal. Then we'll hook it up, and you're going to want to make sure it's going to ask you for various height, weight, and age so you can have the algorithm. And this was our 62-year-old male patient, and his weight was 78 kilos and 71 inches. And then we're going to hit accept data. And at this point, we're going to want to, we already have our signal, we're going to want to start optimizing our signal. And as you can see here, we pretty much have obtained a really good descending aortic blood flow signal, and we want to optimize it. So what we can do is we can hit the show PVD button, and then we can slowly twist the probe in through the mouth and just see where the best height that we're obtaining, and you can see the blue line is tracing the height that you were at. So as you rotate the probe, you'll see the blue line either rising or falling depending on the signal. And so the best signal would be the highest point that blue line has, and that's your highest peak velocity. And so that's what you'll go for. And then you can hit a auto gain button, which will optimize the signal-to-noise ratio of the probe. And that takes a few seconds to go through the algorithm to figure out what the best signal-to-noise ratio is. And it found the gain was around 5, so it was right in the middle. And then, depending on how many cycles you have set, you'll start to obtain numbers for cardiac output, stroke volume, whatever parameters you have set in the cardio-Q monitor. When I'm tending to want signals, when I'm tending to want to look at data and obtain actual numbers, every time I will re-optimize the probe, put my hands on the probe, and make sure that's the best signal that I'm getting. And at that point, once I find my best signal, I'll allow, depending on this has 5 cycles, so I'll allow for 5 heartbeats to go through and make sure that I get a steady state on the signals, and then I'll freeze it. And this is the data that I'd write down for my patient. So if I want to do an intervention, give fluids, start pressors, I have a point where I can look back and say, okay, these are my numbers that I obtained as baseline. I'm doing an intervention, and does that intervention change my numbers in the appropriate way? Then simply, if you want to run this as a continuous monitor, you just hit run. So this is oral insertion. I'm also going to go over nasal insertion as well. So the cardio-Q, the The DP240 probe can also be inserted intranasally, and you're going to want to insert typically between the second and third depth marker. You're going to want to lubricate the probe just like for oral insertion, and obviously pick whichever nares is the best patency, and simply place it in through the nose, not forcing if there's resistance, but it should kind of proceed smoothly through the nose. Sometimes you need to do a little extra twisting to get it around the ET tube. And we're going to go between the second and third depth markers we talked about before we start to focus our ultrasound probe. And that's the appropriate depth right there. The benefit of the nasal insertion is it tends to be a little more stable than oral insertion as far as maintaining your signal. Higher risk of epistaxis, nose bleeding from placement in this area. For further information, I'd refer you to the Deltex Medical website.